Rational use of inhaled corticosteroids for the treatment of COPD. A plain language summary. Chronic obstructive pulmonary disease, or COPD for short, is a common treatable disease in which the airways narrow and the amount of air you can breathe out is reduced. People with COPD experience debilitating symptoms such as breathlessness and cough, which reduce quality of life. When these symptoms flare up, this is called an exacerbation. Long-acting bronchodilators, typically in combination, are the main treatment for COPD. Long-acting bronchodilators relax airway muscle, causing airways to widen. Either alone or combined with other treatments, long-acting bronchodilators reduce symptoms and exacerbations and improve quality of life. Inhaled corticosteroids, or ICS for short, which are commonly used to treat asthma, are sometimes used in COPD. Global treatment guidelines recommend adding ICS to long-acting bronchodilators in a small proportion of patients, which represents between 10 and 30% of the overall COPD population. However, studies conducted in routine clinical practice show that ICS are prescribed to between 50 and 80% of patients with COPD, creating an imbalance between the number who should be treated and those who are treated. Guidelines written by the Global Initiative for COPD recommend that ICS should be reserved for patients with at least 2 moderate exacerbations per year, or at least 1 leading to hospitalization, and a high level of eosinophils in their blood, 300 or more cells per microliter of blood. Eosinophils are a type of white blood cell involved in inflammation, and high levels of eosinophils are associated with asthma and allergies. If patients have a current diagnosis or documented history of asthma, ICS should be used. For patients with lower eosinophil levels, ICS may also be considered, but only if patients are having persistent exacerbations despite long-acting bronchodilator therapy, and after a careful assessment of the expected risks and benefits of treatment. ICS withdrawal should be considered for patients on ICS who do not meet the above criteria or who develop pneumonia, a serious potential side effect of ICS use. Several randomized controlled trials, IMPACT, ETHOS, TRibute, and CHRONOS, have assessed the effects of adding ICS to long-acting bronchodilators in patients with COPD. In these trials, adding ICS to long-acting bronchodilators was shown to reduce mortality and exacerbations in the trial population, but was associated with an increased risk of pneumonia. However, a number of issues affect clinical interpretation of these results, including the selective patient population studied and the withdrawal of ICS in patients randomized to non-ICS treatment. Furthermore, the apparent survival benefit attributed to the ICS component was not demonstrated in ICS-naive patients and is not endorsed by health regulatory authorities. Observational studies are carried out in broader patient populations than clinical trials and without the skewing effect of drug withdrawal on randomization. Therefore, they can provide a more complete picture of the benefits of ICS. In these studies, adding ICS to long-acting bronchodilators was either equally or less effective in reducing exacerbations and, again, was associated with an increased risk of pneumonia. These findings reinforce global treatment guidelines written by the Global Initiative for COPD. These recommend that ICS should be reserved for patients with COPD whose clinical features suggest that the benefits of treatment will outweigh the risks. For initial treatment, this includes the small proportion of patients with 2 or more exacerbations per year, or 1 leading to hospitalization, high blood eosinophils, and/or current or a documented history of asthma. Most other patients should be prescribed a combination of long-acting bronchodilators. For patients with lower eosinophil levels, between 100 and 300 cells per microliter of blood, ICS may also be considered, but only if patients are having persistent exacerbations despite long-acting bronchodilator therapy, and after a careful assessment of the expected risks and benefits of treatment. ICS withdrawal should be considered for patients with no current or documented history of asthma, no COPD exacerbations in the previous 12 months, and a blood eosinophil level under 300 cells per microliter of blood. ICS withdrawal should also be considered in patients who develop pneumonia, a serious potential side effect of ICS use.